The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shannon McKernan, and today I'm interviewing Dr. Michael Morris, an author on optimizing anti-cancer therapy in non-castrate metastatic prostate cancer, an American Society of Clinical Oncology clinical practice guideline. Thank you for being here today, Dr. Morris.
Thank you very much. It's a pleasure to be here, and thank you for having me on.
First, can you give us a general overview of what this guideline covers?
Of course. So for many years, the standard of care for patients who had newly diagnosed prostate cancer who were not on testosterone-lowering therapy, which we call castrating hormonal therapy, the standard of care for treatment of those men was to receive such therapy. And that either came in the form of a GnRH agonist or a GnRH antagonist or an orchiectomy. And this was considered to be the standard of care for many years. The new standard of care addresses therapies that would be added to standard androgen deprivation therapy, these castrating hormonal therapies. At least for some patients, it does look like adding additional therapy to androgen deprivation therapy, or what we would call ADT, can have clinical benefits for those patients.
What are the key recommendations of this guideline?
All right, so the treatments that we're talking about involve two additions to ADT. One is in the form of a chemotherapy called docetaxel, and the other is in the form of an additional hormonal therapy called abiraterone. What we're talking about is two standards of care. One would be ADT and docetaxel, or ADT and abiraterone for men with what is either termed non-castrate metastatic prostate cancer and what others might call castration-sensitive metastatic prostate cancer. And that's men who have prostate cancer that is just beginning to be treated with ADT. The guidelines now recommend that at least certain populations be considered for these treatments, and that's based on several studies that have now been performed and resulted and published. So the new recommendations are based on, in terms of the abiraterone, two clinical trials. One is the Stampede trial, and one is the Latitude trial. The Latitude trial examined men who had metastatic non-castrate disease that they termed high risk, and those high risk patients had to have 3 or more bone metastases, or visceral disease, or Gleason 8, 9, or 10 disease, and they needed to meet 2 of those 3 criteria. These men were either randomized to abiraterone and ADT or ADT alone. The men who received the abiraterone and the ADT had an improved overall survival relative to the men who received the ADT alone. They also received 5 milligrams of prednisone in conjunction with receiving the abiraterone. So on that basis, we would say that men who have non-castrate metastatic prostate cancer who meet these high-risk criteria should be considered for a standard of care of ADT and abiraterone. There's another trial that addresses the same population except without the high-risk caveat, and that's the Stampede trial. Those men also have non-castrate metastatic prostate cancer, and those men that trial also included men who had non-metastatic disease as well. So there was quite a range of men that were included in the STAMPEDE trial, but all of them had, again, non-castrate or castration-sensitive prostate cancer, and those men were randomized to ADT and abiraterone or ADT alone. And in that trial also there was a survival advantage in favor of ADT and abiraterone. So there could be an argument made that even men with low risk disease or those who don't meet high risk criteria as defined by Latitude, maybe those men should receive ADT and abiraterone as a standard of care as well. The guidelines don't address non-metastatic disease, which did include a portion of the STAMPEDE trial, and so we're not going to address that in this podcast. But at least as far as metastatic non-castrate prostate is concerned, we would recommend that certainly the high-risk men receive ADT and abiraterone, and that has now an FDA approval as well. And it should be considered for men with who don't meet the high-risk criteria but have non-castrate metastatic disease as well. Now, for the men who have, for the docetaxel standard of care, which is a separate standard of care that this guideline covers, that's two other studies. One is, that involves other studies than the ones I just talked about in part. One is the CHARTED trial, and the other is another arm of the same trial that we were just talking about, which is the STAMPEDE trial. So the CHARTED trial took men who had metastatic disease, and that was newly diagnosed. Again, these patients had not received significant exposures to hormonal therapy in the past, and it randomized men to either docetaxel for 6 cycles given every 3 weeks at 75 milligrams per meter squared, plus ADT, or ADT alone. These men enjoyed a survival advantage if they received the docetaxel. The STAMPEDE trial, the arm that we're talking about, there was actually several arms in which similar comparisons were made of ADT versus ADT and docetaxel. The arms that we're talking about specifically are those that made the comparison of ADT versus ADT and docetaxel alone. There were other arms in this trial that contained docetaxel and zoledronic acid. We're not talking about those arms right now, though for any arm that contained docetaxel in that trial, there was a survival advantage to receiving docetaxel. So there is a little bit more of a complicated story with the docetaxel standard of care. It might seem from what I just said that everybody who has metastatic non-castrate prostate cancer should simply receive docetaxel, and some people might interpret that as such. I think that the greater care needs to be taken in considering this standard of care because there was a subsequent analysis after this trial was done looking at men who met what was termed high volume criteria, which was pre-specified in the protocol, and this was a pre-specified analysis as well. And those men had 4 or more bone lesions, 1 or more of which needed to be outside of the vertebral column or the pelvis. And it also, in high volume disease, also included men who had visceral disease. And it looked at those men as opposed to the other groups of patients who were included in that study, and it was only the men who had high volume disease that appeared to enjoy the survival advantage, while the men with low volume disease appeared not to enjoy a survival advantage in that study. They had a hazard ratio of 1. Now, this was a subset analysis, and the study wasn't designed to have adequate power in order to analyze those two populations specifically. with statistical significance. So one always has to take that with a certain grain of salt. But I think that one does need to be careful then about potentially not over-treating men with docetaxel. And I think what the guidelines carefully navigate here is to say that men who do have high volume disease should certainly be considered for ADT and docetaxel as a standard of care. And those who do not meet those criteria and have low volume disease might be considered for ADT and docetaxel as a standard of care. And we recognize that there's some ambiguity there, but that ambiguity is just simply reflecting the data.
Why is this guideline so important, and how will it change practice?
Well, really, for many years and indeed decades, treating men who had newly diagnosed prostate cancer or newly diagnosed metastatic prostate cancer is really quite straightforward. You just lowered their testosterone with a testosterone-lowering agent, and there was really nothing that we knew of that improved their survival. So this is really quite a revolutionary change in that we're bringing therapies that usually would be used for much more advanced disease that was termed castration-resistant metastatic disease to the non-castrate or castration-sensitive setting. And what it revealed that there was really significant and tangible patient benefit by doing so. And so this earlier application of docetaxel and abiraterone really does prolong survival in a significant way, with about a 40% improvement in overall survival. And so seeing such significant gains in the early application of docetaxel and abiraterone is really quite significant and should be factored into every clinician's decision-making when they see a man who meets these criteria and who has non-castrate metastatic disease.
And finally, how will these guideline recommendations affect patients?
Well, I think that the reality is that for any given patient who has newly diagnosed metastatic disease, they want to live as long and as well as they can. So, and many men feel that treatment with hormonal therapy in the way that it used to be, which was just testosterone-lowering agents alone, saving some of our best therapies for later in the disease. Many men were eager to treat their disease aggressively and upfront. And I think that these studies do validate such an approach and would indicate that for many men, who have non-castrate metastatic disease should be getting more than ADT alone up front. They should be getting either ADT and abiraterone, or they should be getting ADT and docetaxel. Now, which approach is better than the other, we don't know. There are some things to think about in terms of advantages of one over the other. The first is that for ADT and abiraterone, that really is long-term therapy. The duration of the abiraterone treatment is really until the emergence of castration-resistant disease, and that could be years. So I would say that it's important for a man who, doesn't want to be on continuous therapy supplementing the ADT, that perhaps that's not the best approach. On the other hand, abiraterone is easy to take. It's oral therapy as opposed to IV. And so there's a certain convenience factor to that should be considered in terms of the patient convenience. Financially, though, abiraterone is an expensive drug, and when you think about the monthly cost, if the patient doesn't have a good drug coverage for oral medications, the cost can be prohibitive. The advantages of chemotherapy are that it's a limited course of 6 doses given every 3 weeks. So there's a certain convenience of just getting your therapy over with in 18 weeks. And from a quality of life standpoint, it does look like the quality of life data would indicate that you do have some chemotherapy related effects on quality of life during treatment, but those generally do resolve when examined a year following treatment. Chemotherapy from a financial standpoint is affordable for many patients because it's an in-office treatment. And so there can be a convenience factor and a financial factor in favor of chemotherapy and over abiraterone. So, which might be more preferable from a patient perspective depends on their financial situation, on whether they want to have continuous therapy versus a limited course of therapy, whether they feel more comfortable with an oral agent versus an intravenously administered agent, and other factors as well. So from a patient perspective, there are two standards of care, two choices, each with some pros and some cons. Now, medically speaking, we don't know which might be better than the other for a given patient. So, for example, are there certain grades of tumor that are more susceptible to chemotherapy than abiraterone? We don't know that. Are there certain classes of patients, such as those who might have a neuroendocrine component to their disease, that might be more amenable to chemotherapy than abiraterone? We also don't know that. And then finally, we really don't know that there's these distinctions between high volume and low volume for the patients who are candidates for chemotherapy, or high risk and low risk for the patients who might be candidates for abiraterone. We don't know if those are the optimal definitions by which to be considering and separating these patients. And so further work needs to be done in refining those definitions and seeing if they're applicable, and if there are some patients who benefit more than other patients medically, whether based on risk or burden of disease or disease distribution or disease grade or subtype, that might benefit from one therapy or another. All of those questions need to be answered for future study.
Great. Thank you for your insights on this guideline, and thank you for your time today, Dr. Morris.
Thank you very much, and it's been a pleasure presenting these exciting new data. And certainly there's more to follow in terms of more details on how these standards will evolve over time and become more refined.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.